Thank you very much to the organizer for giving me, where is the pointer? Here, sorry. I'm a little bit sick, so I hope everything will be okay. So thank you very much for the organizer to give us the opportunity to present our work today. So as you all know, that at least 10% of SARS-CoV-2 infected individuals will suffer from persistent symptoms more than 12 weeks post-COVID infection, and the reported symptomatology is really diverse. More than 200 symptoms have been reported, have been described up till now. They're physical and neurological, they are debilitating. And what is really important, it varies between individuals. And as sure as you know here, because you're already here, but this is the long COVID is a huge public health issue that will affect a lot of people worldwide. So as we've been mentioning up here, there are a lot of potential mechanisms for long COVID pathogenesis. They are not mutually exclusive, so it can be viral persistent, as we showed that, systemic also inflammation, reactivation of viruses, dysbiosis, microvascular, autoimmunity, and also metabolic dysfunctions. And from all the work that we've been working in the lab, today we will show you what we have results in the immunoinflammatory response and how they're affecting in long COVID patients. So the objective of this work was to analyze soluble markers to elucidate a potential cytokine profile in the underlying persistent symptomatology. So before that, I would like to show you some results, some clinical results that we did as symptomatology-based clustering, a little bit like it was shown in the previous session. So our cohort, we have a cohort of 1,000 individuals, the king cohort, that it's a little bit heterogeneous. It was built during the acute, in March 2020. So we have a lot of follow-ups of hospitalized people, and it's a follow-up of 2 years. We have included also uninfected controls, people without persistent symptomatology. And what is important is that we have 645 individuals that have long COVID. And this is some updated results that we have published previously this year. But here we're showing you the cohort as it is now. So for this study, we used the definition of the WHO as a long COVID criteria, and we accepted individuals with long COVID with a confirmed test by PCR or by RAT, also by serology, because we had a lot of individuals included before the vaccination. And also we accepted clinical diagnosis. What is really important in this cohort, and maybe it's a little bit different of other ones, is that we have a systematic collection of a comprehensive list of symptoms and functional scale that is done by a physician in a face-to-face interviews. So it's a physician who evaluates the long COVID patient. So we are really sure that it's long COVID and the symptoms are well described. And also, since it's a hospital-based unit, maybe we have the more severe cases of long COVID that they are reaching to the hospital. So the prevalent symptoms are really, really common, as other papers have described. They have a lot of fatigue, also arthralgias, myalgias, dyspnea in the cardiovascular, chest pain, tachycardia, and also a lot of neurocognitive complaints, brain fog, memory loss, and a lot of headaches, and also mucosal dryness and hair loss. So a little bit quite what other people have described. So what we did is a symptomatology-based cluster. So we identified, in our case, 3 different clusters. And when we do a heat map with here you have like all the symptoms, and here the different clusters, what we can see is an additive effect of symptoms. So the first cluster, it's what we call them like the less severe long COVID, because they show like only fatigue and dyspnea as the main symptoms. The cluster 2, they have on top of the fatigue and the dyspnea also the neurocognitive complaints, arthralgias and myalgias. And then cluster 3 is the one that is most severe and have a lot of a large range of symptoms. So putting this in a little bit of characteristics, so mainly as has been postulated before. The sex is mainly females, and basically what is really striking in the cluster number 3, that the one that is more severe for long COVID, there are more females than males. The age is really similar among the 3 clusters, around 47 million age. The number of persistent symptoms, as you can see in the heat map, it's increasing, so the median is 5, 10, and 17. And the hospitalization, it goes on the other way around. So the one that has been hospitalized, they're mainly in the cluster 1, and then there is a decrease. And although what is really important also that mainly the ones that they are in cluster 1 have been cured compared to the other clusters. So coming back to the cytokine characterization, so what they did is a immunological sub-study. So we selected 314 samples. So to have a clean data, what we selected unvaccinated and also unvaccinated samples from patients, and also to avoid reinfections that could alter the inflammatory profile. The samples were collected from 5 to 13 months from SARS-CoV-2 infection, and we had 140 long COVID patients, 96 recovered, and also we had uninfected that coming from the cohort, but also we included some pre-pandemic samples. So we did a large panel of cytokine, pro-inflammatory cytokine panel. And just to coming back a little bit more about also the characteristics of the preselected samples, so basically are more or less the same as I presented you before. The only thing that it was unfortunate, but we had a lot of females in the long COVID group, but not as many under-recovered. So it's something to take into account. But since we wanted to work with unvaccinated and everything is what we had. And another thing that I want to that we pay attention is the comorbidities. So there were more prevalence of obesity, allergy, autoimmune disease, and asthma in the long COVID group compared to the recover. So these are maybe factors that may develop. So most of the samples were collected 8 months post-infection, so we are really quite far away from the initial infection. So from the 30 samples, 30 cytokines that we measure, only 6 that were significantly different between the 3 groups, between the long COVID, recovered, and infected. And I will go a little bit through them, all of them, because we have like 3 different situations. So the first one is that we have differences between the uninfected group versus the infected group, regardless of they have long COVID or not. And this is the case of HGF. And maybe just because this is an upregulation of this marker will reduce the inflammation and limit the tissue injury and promote tissue repair after an infection, as it can be in this situation. Also, iotaxin that has been related to neurocognitive symptoms, we see the same situation, that the main difference that we found is between the uninfected group and the infected group. We don't see any difference between the long COVID and the recovered group. So also we have MACP1, that is the same situation. We have the main differences between the uninfected and the recovered, and then infected and long COVID. No differences between the 2 infected groups. IL-7 is a little bit more strange situation that we don't still understand, because the uninfected group is significantly different from the recovered, and it's equal to the long COVID group. So we are still trying to figure out what's going on here. And IP10, basically, the differences between the uninfected and the long COVID group, and the uninfected and recovered are really similar. So, and what was more striking for us, and the marker that we like the most, is IL-RI1, that we have really clear differences between the uninfected, the recovered, and the long COVID. It's like a gradual increase of this marker between the 3 groups. So IL-1 is an endogenous IL-1 inhibitor, and that what it's a specific receptor antagonist of the IL-1 cytokine to the IL-1 receptor. So basically, when you have here when IL-RI1 binds to the receptor, there is no signal transduction, and it's an agonist, but you need large molar excess to be able to do this inhibition. and to block this IL-1 activity. IL-1 array has been involved in inflammation, cardiovascular disease, and metabolic disease, and in other disease. So we wanted to evaluate how we've seen like this pathway. Basically, so here we have the the IL-1 beta. We don't see differences between groups, even statistical significant, and we see, as I was showing you before, the three groups differences. So when we do the ratio, because it was important, no, the number of molecules of IL-1 between IL-1 beta, we clearly see that the long COVID group has lower levels of this, have lower ratios compared to the other two groups. So we think that it could be a nice pathway to study. So since we were talking about clusters and differences between individuals in long COVID and different severities, when we did the same analysis in the clusters, we did not observe any differences between the long COVID clusters. So I'm coming back just to the specific IL-1 beta and IL-1, we didn't see any difference. So it's independently of the cluster that they belong, of the cluster severity, which was quite surprising. So what we did in exploratory analysis, and we need to work a little bit more on that, and look for every symptom which cytokines were out there. So if they have this symptom, they were separating for yes and no. And IL-1 array, it was present in a lot of symptoms. So we have people with myalgia have higher levels, also with arthralgia, chest pain, tachycardia, headache, dizziness, and diarrhea. So as you can see, IL-1 can be a good biomarker. So we need to still work on how to analyze this more deeply, because since a lot of symptoms they are collinear, so the same patients have the same symptoms, so we need to evaluate this more deeply. So just in conclusion, some of the cytokines remain altered in individuals infected by SARS-CoV-2 independently of the persistent symptom after 6 months from acute infection. And the differences between long COVID and recovered individuals are really limited after correction, so there's great importance to include recovered individuals in the long COVID studies. And the symptomatology-based clustering does not help to elucidate the cytokine profiles. Instead, we need maybe to focus more in the systems one by one. And just to finish, the IL-1 array can be a potential biomarker for long COVID. It is gradually increasing long COVID after recovered, after uninfected, and has been associated with a lot of symptoms. So just to thank all the people from the unit, from the post-COVID unit in Badalona, in Hospital Germán Sierra Puigdol, the people who have done the work, and of course, the patients, know that hopefully we can give a little bit of light to their disease. Thank you very much.